Welcome everyone to the latest installment of our GP focused webinar series. This is, as you know, for GP supervisors and registrars. Tonight we're going to be looking at dentistry for GPs. Before we get started, I would like to acknowledge the traditional owners of the lands on which we all meet this evening and to pay my respects to the elders past, present and emerging. So tonight we have the opportunity to take a bit of a deep dive into dentistry for GPs, which, as you know, for many of us is a bit of a black hole. And when Jackie and I were talking about this earlier in the week, I recall many years ago attending a lecture that she gave, and I felt like I had learned a whole part of the curriculum that I had completely missed. And she very kindly told me that actually that was because I probably wasn't taught it, but I think she was being very kind. So before we get started, we'll just go to the next slide. Thank you. And without further ado, I'd like to introduce Jackie Stuart. I think many of you know her, fabulous dentistry academic, and she's going to be taking us through dentistry for GPs. Away you go, Jackie.
All right. Thank you very much. And good evening, everyone. There's been a wonderful turn up, apparently. So I'm finding that perhaps this is very relevant at the moment, particularly in this COVID environment. So my name's Jackie Stuart, and I've got 20 years of clinical experience as both a government dentist and a private dental practitioner. And I've just finished writing my PhD, and the topic is the relationship between dentists and doctors and how this has an impact on patient outcomes. But a deeper underlining part of that is the actual link between oral health and medical health and how poorly understood this is. So I'm thinking that the most important thing we need to do is improve interprofessional communications between dentists and doctors so that we can have a better patient outcome. So when I was interviewing lots of doctors for my PhD, they all said that they really would like some sort of postgraduate education on oral health management techniques in emergencies. And it wasn't being done anywhere. So we've developed this series, and I do it as a volunteer, and I'm very happy, and I hope that you enjoy it. You may have heard it before because I have been lecturing to the med students in JCU for many years now, 5-6 years, but the presentation is updated, and I think it'll be a wonderful reminder of what to do. And we're going to send you home tonight with many practical tips and wonderful ways to solve emergency problems that come into you from dental situations. And I'll take little pauses as we go so that Peta-Ann can collate the questions, and we'll be able to go from there. So the presentation will be in 6 parts, and we'll have a little break after each part so that we can answer any questions. I'm going to speak to you about the dental practice limitations that have been imposed on dental practices during this COVID-19 pandemic. It's really been quite a challenge, and although we have flattened the curve and have returned to level 1 restrictions now, it's really possible that as people re-emerge from isolation, the incidences of COVID-19 infections may rise. And these practice restrictions may be imposed again, and this will directly impact you guys as medical practitioners. So the second part of the presentation will be to talk about the prevalence of dental presentations to medical practitioners in normal times. We're going to learn how to speak the dental language so that when dentists and doctors communicate with each other, we'll all be speaking the same talk. So we're going to learn about OPG interpretation, the dental tooth numbering system, and the basic anatomy of the tooth so that we can understand how caries occurs and how abscesses form. So probably one of the most useful things you'll ever learn is how to give a dental anaesthetic, because if a patient comes into you with a dental problem in the middle of the night, at least you'll be able to numb them up before they can see the dentist the next day. We're then going to discuss antibiotics and why this is really not the best solution for dental emergency management, although it is usually the thing that most doctors will reach for straight away. I'm going to teach you some alternatives so that you don't have to use antibiotics because they don't work. And then we're going to talk about some of the emergency common presentations that will come to you from a dental point of view. And I'm going to give you some tips and tricks of the trade so that you can understand how to treat these problems effectively.
And it's fair to say, Jackie, that I've been terrifying you by saying you have to do all of that in under 60 minutes. So well done, and off you go.
Okay, I'm on it. So studies suggest that COVID-19 may be airborne through aerosols, which are formed during dental and medical procedures, or indirectly through saliva. So this wonderful picture on the slide here shows when a dental drill actually has the water hitting it, the incredible aerosols that are generated. So a patient that actually has a confirmed diagnosis of COVID-19, and they will require urgent dental care, and it will be done for them, but it will be provided in a hospital setting, and it will be done with transmission-based contact and airborne precautions. And these include the need for the patient to be treated in a negative pressure room with dental staff wearing P2 N95 respirators that have been previously fit tested and then fit checked at the time of use. When restrictions are placed on accessing routine oral health care, a significant concern exists for overall patient dental medical care. So during this pandemic, more patients than usual may access accident and emergency hospital departments. When we were recently in level 3, which was only 5 weeks ago, dentists were in level 3 restrictions, I'm sure that a lot of medical practitioners saw many patients, many more patients than they would be used to seeing. These patients may potentially need hospital admission for the management of acute dental infections that may threaten the airway and require intensive care. So this is quite a busy slide, so don't get too excited about it, but what I really want to do is just explain to you very briefly the restrictions that dentists have had to work under during the past couple of weeks. So at the moment, we're under level 1 restrictions, and that means that if a patient has got a confirmed case of COVID-19, then we can't really do anything. We need to defer non-urgent treatment. If they're in pain, of course, we'll treat them as I talked about in the previous slide. But basically, level 1 restrictions is what we're working under now. We can do just about everything, but with quite severe restrictions in waiting room numbers, hand washing protocols, and just being particularly careful about making sure our patients are well. Level 2 restrictions, we defer all non-urgent treatment for people who have got COVID-19. But we can do treatments, but we try to avoid them having aerosols being generated. So normal filling and drilling we try to avoid. But if we really have to, because a patient's got problems, then we'll do it under what we call a rubber dam. Now, a rubber dam, I don't know if anyone's ever seen that, but if you've ever had a root canal treatment, a rubber dam is where the tooth sticks through a piece of plastic rubber, and the environment of the oral environment is completely isolated from the tooth, and the tooth can then be drilled without any saliva being attached to it. So level 2 restrictions, we can do most things, but if we have to do drilling with a high speed, we do it under rubber dam.
And I assume, Jackie, the dentists and the assistants would all have to be in full PPE for this, would they? Because
no. Just, well, normal PPE, not N95 respirators, just normal, because dentistry is extremely infection control conscious anyway.
Yeah.
So, but that's just the added thing. Okay. Level 3 is what we were at only 5 weeks ago. And during level 3, we couldn't do really anything very much at all. We had to defer all non-urgent dental treatments, which included routine examinations. So we didn't really do anything, and we're a bit worried about the long-term results of this. People have put off their examinations and their cleans and polishes, and we'll see what happens, whether that means that their dentistry long-term is going to suffer. I also know that during the level 3 restrictions, the base hospital here, the dental surgery closed down. And so people couldn't actually go into the dental surgery. That was a PPE issue. We didn't have enough protective equipment. It all got diverted to the hospital, not to the dentists. Level 4, we haven't reached that. Goodness knows, I hope we don't. But if we do, then all dental treatments for patients not fitting the risk categories of urgent, which is facial swelling and broken jaws and teeth, they all have to be diverted. And the final level restrictions is that any dental treatment without express permission from the public health authorities is not to be done. So quite interesting, and this will impact on your medical practice if we need to go back into any level of restrictions when we have a second wave of COVID. But as far as you guys need to worry, or don't worry, a patient with a significant dental emergency who is at risk of COVID-19 infection or with a confirmed diagnosis will most often be able to be managed with analgesics until the patient has reached the end of any mandatory quarantine period or is no longer at a risk of being infectious. So back in the day before COVID, this is the data that we had, which showed that people who are unable to access timely dental treatment may develop serious infections and be admitted to hospital. So in your practice, you may have come across some sort of dental emergency, but it's actually very, very common. So that top slide shows the number of preventable hospitalisations, and in Queensland, it was about 14,000 in 2016 to 2017. Between 2012 and 2014 in Queensland, dental conditions were the fourth most common reason for someone to be put in hospital for a condition that is preventable. In Tasmania, where I was doing my PhD in 2014, it was the most common reason. So from 2016 to 17, there were 70,200 avoidable hospitalisations for dental conditions and 750,000 encounters with GPs for dental-related issues. 750,000 consultations that should have gone to the dentist and went to you instead. But medical practitioners generally lack substantive training in dentistry, and very few doctors at emergency hospital departments have been trained in the management of dental problems. And that's why I'm here. I'm going to give you some tips and tricks so that you can try and avoid putting a patient in hospital for a dental problem.
Jackie, can I just ask you to pause there, because I'm always astonished when I see those figures, and I know that, this certainly isn't the first time I've seen them. Could you give us a flavour of what on earth those hospital admissions are for? Is it?
Yeah, and I'm in the presentation. Thanks.
Yeah.
As we go through, I'll show you some pictures of things like Ludwig's angina, which is a very nasty infection that closes the airway. We have dental abscesses that cause a lot of pain and broken jaws, but it's mainly dental infection that's not treated.
So most infection. Someone in the audience, one of the participants, has made the comment that I knew was going to come, which is that patients will often access GPs or EDs because they may not be out of pocket, whereas going to a private dentist certainly would be very expensive and perhaps inaccessible for some people. Exactly,
and that's the next point that I was going to bring up. So a potential hospitalisation will actually cost the taxpayer $38,000. That's the data that's been out there. And it shows that 27% of all Australians avoid visiting a dentist due to the cost, and approximately 400,000 people are on public waiting lists. But the structure of dentistry and the way it is funded is different to medicine. So dentistry is not covered under Medicare. So only 15% of the population can get free dental care from a dental hospital, and the other 85% have to pay for themselves. And so that's why they'll come to you. One, because we're expensive. Two, because in rural areas we're rare. We can't just set up a practice in rural Australia. We need a certain population base to make it a viable thing to have a practice. Otherwise, economically, we can't survive because we are a business. We're not funded by Medicare. So I hope that answers that question.
Thank you. Yes, keep going.
Okay. So I think what we need to do to improve communication is we need to learn the same language. And one of the main things is to do an OPG. A dentist will love it if you have an OPG and you've actually looked at it and you've identified the problem and you can refer them with the OPG. We know that the image provides an overview of the state of the dentition, as well as information regarding the mandible, the maxilla, the sinuses, and the TMJ. Some pathology can very readily be picked up on OPG, like ameloblastomas, and the dental abscess can be seen, and perhaps an odontogenic cyst on the bottom there associated with that wisdom tooth with the green arrow. The anatomy of the healthy normal tooth. It's important for you to understand this briefly so that you can understand when it's not healthy. So the enamel is on the outside of the tooth, and it is the hardest structure in the animal kingdom. And underneath the enamel, we have dentine. Dentine is quite soft and it's got tubules running through it. So once the enamel is breached by decay and it gets into that dentine, it goes through those dentinal tubules into the pulp, which is the nerve of the tooth. And that's when you get toothache. And that pulp is attached to through the tooth apices to the blood supply. The tooth is attached to the bone, to the alveolar bone, by periodontal ligaments. And these ligaments act like little shock absorbers that allow a tiny bit of movement in the tooth. If the tooth is knocked out completely, then that nerve supply is severed and those periodontal ligaments are broken. So it's imperative to get that tooth back in as quickly as possible, being really, really careful not to touch those periodontal ligaments because we want them to reattach. We're going to talk about this a little bit more as the presentation goes on, but it's quite difficult to get that blood supply to reattach unless the tooth is very, very young and the root apices aren't formed. So the slide, the OPG of the normal 7-year-old on the right-hand side, shows those permanent teeth with the open apices. And if you can attach the tooth in when they're quite open like that, then you will have a bigger chance of that nerve supply reattaching. I love this slide. This is a normal slide. It's crazy. Look at all those teeth everywhere. But I want you to particularly take note of the position of the permanent teeth underneath the baby ones. If a patient loses their baby tooth prematurely, for goodness sake, don't try and reimplant that tooth because you have to remember the permanent tooth that's underneath and you may well damage it. So if you take nothing else home tonight, remember that. Don't reimplant baby teeth. So to speak the same language, just briefly, the teeth are numbered. The permanent dentition, we call it 1-1, 1-2, 1-3, not 11, 12, 13. And the quadrants are divided up in the top right-hand quadrant is 1-1, then 2-1, 3-1, 4-1. And going over to the deciduous teeth, the quadrants are numbered 5, 6, 7, and 8. There are 32 permanent teeth and 20 baby teeth. One of the questions that came in earlier was how to identify a wisdom tooth. Well, it's the number 8. It's right up the back. So you count from 1-1 right up to 1-8 and you've got your wisdom tooth. And that will allow you to communicate with that dentist. The first tooth to erupt in the baby's mouth is that bottom first little incisor at approximately 6 to 8 months, followed by the second lower incisor and then the upper ones. The first permanent tooth to erupt in a child's mouth is the first molar at 6 to 8 years. And the final tooth is the wisdom tooth, the 8. And that is around about the age of 17 to 26. So if a patient comes in and their face is quite swollen and they're in a lot of pain and they're about 17 to 26, the first thing you do is you open up and you have a look and see if the 8 is there, the number 8 tooth, and if it's got gum over it and it's swollen, then perhaps it's just a wisdom tooth erupting, not an abscess. So dental anaesthesia is such a useful thing for you to learn how to do. This is the ideal scenario. We've got the patient with a toothache. They go to the doctor because there's no dentist, and the doctor gives them an anaesthetic. And the doctor then gets on the phone and calls their friend, the dentist, who they meet for coffee once a week. And the dentist gets his surgery ready. The patient gets in the car and drives to the dentist pain-free. And then the dentist treats the patient and the patient's happy. But unfortunately, this communication between the dentist and the doctor breaks down. And that's to the detriment of patients. So although the efficacy of using a mouth rinse before commencing dental procedural treatments can't be guaranteed to have a significant effect on viral load in a patient with COVID-19, it is recommended by the ADA that all patients should be asked to undertake a 20 to 30 second pre-procedural mouth rinse with either 0.2% iodine 1% hydrogen peroxide, or 0.2% chlorhexidine rinse, an alcohol-free one. The nerve we're trying to numb up is the trigeminal nerve, the branches of the trigeminal nerve. We have the maxillary nerve, the branches up the top. Down the bottom, we have the inferior dental nerve, which supplies the teeth, as well as the lingual nerve, which supplies the tongue. A maxillary infiltration is a really easy injection to give. It involves the extravascular placement of local anaesthetic in the region to be anaesthetised. Infiltration injections are most routinely used to anaesthetise these top teeth, and xylocaine or lignocaine is the most common anaesthetic choice, but marcaine is often used, and I know that you have this in hospitals, and that gives a longer duration. So what you do is you find the tooth that needs to be anaesthetised, and you think of the tooth as an iceberg. You've got 1/3 of it on the outside that you can see, but 2/3 of it are underneath the gum level in the bone. So we aim to that area where the root tip is likely to be, and we put pressure on that area. If you've got some topical anaesthetic, that's awesome. By all means, use it. But if you don't, then just put pressure with a cotton bud. After a while, the patient will say to you, "Hey, doc, take that off. That's hurting." But they'll be numb. And then you can gently, gently pop that anaesthetic in and put it in at a 45-degree angle and just drip the anaesthetic ahead of the needle tip, and make sure your anaesthetic is at room temperature. Don't get it straight out of the fridge. And I can almost guarantee that'll be a pain-free injection. The lower injection, the inferior alveolar block, is a more difficult injection. It aims at the deepest part of the ascending ramus, which is parallel to the occlusal plane and lateral to those pterygomandibular raphe. The needle tip is put in at this point and will hit bone with the bevel aimed away to assist in the needle deflection and the direction of the local anaesthetic solution. So what you do is you go in, your needle goes in halfway, and you must aspirate, because remember the anatomy, we've got the inferior dental canal down there with the nerve bundle and the nerves and the blood supply. So you pop the injection in and you must aspirate. You draw back on the injection, and if you get a positive aspirate, if you get blood in that injection, then you need to pull back just a little bit, aspirate again, and if you have a clear aspirate that time, then gently deposit the anaesthetic in that region. And the inferior alveolar block will numb all of the bottom teeth on one side. It's quite a difficult injection, and when I was doing my PhD and interviewing all the doctors out in rural Queensland, I interviewed about 80 of them, only 3 had ever been taught how to do an inferior dental block. There is an alternative, and hallelujah, it's the mandibular infiltration injection. This is a very easy injection to give, exactly the same as the maxillary one. And the only reason we can do it is because we use a particular type of anaesthetic called articaine. So articaine was introduced and allows success rates for mandibular buccal infiltrations of between 64 to 70% in adult dentitions and just about 100% in baby teeth. But I'd argue with that and say up to 90%. Towards the end of my clinical practice, I was getting 90% success rate with infiltrations with articaine. So there we go.
Jackie, can we just go back to that back on slide? Some practical things here. We wouldn't ordinarily carry articaine. So you're suggesting that rural GP clinics, EDs carry a bit of articaine. Do you think that's a reasonable?
I do. Yeah. I really, really do. I think it's essential. And the next slide shows what they look like, and you can actually get injections that are disposable so that you can put those little cartridges in. You can buy them.
So that was my next question. We often only carry lignocaine, you know, in the bottles that you crack open and you pull out. So what gauge needle would you use?
Okay, yes, it's all there. So if you have that picture there. So they're very fine gauge needles. I can't actually remember the exact gauge of it, but it's written on the box if you can zoom in there. But if you get a box of articaine like this, it'll last forever in the fridge. It really will. And the injections, you could share it amongst a couple of practices. You only need a few, but I really advocate that we have a few of these common things I'm going to talk to you about tonight in your emergency dentistry box. The Royal Flying Doctors should have them, the hospital department should have them, and certainly private practice should have them. It'll just get you out of so much trouble. If you can just do something proactive for a patient with toothache and get them out of pain, they'll love you forever. Otherwise, you're standing there and you just can't really do anything to help them.
And Jackie, it might be worth just saying at this stage that, as you know, we do the Dentistry for GPs practical day across much of Queensland. Of course, we've had to put that on hold this year because of COVID-19, but we are hoping to run 2 one-days later in the year. And we will certainly let people know. And that's a completely practical day using the dental heads and so on. So people could have an opportunity to practice doing these procedures.
Yeah, that's excellent. That's JCU in Cairns. That's lovely. Oh, they did that last couple of years, I think. Yeah, very good. So is that fine, Peta-Ann? Anything else there?
Yeah, there are quite a few questions coming up. There's one particular one. Does articaine last as long as bupivacaine? No,
it doesn't. But it permeates the mandible very, very well. And so it's useful. Nothing lasts as long as Marcaine, but Marcaine won't penetrate the mandible unless you give an inferior alveolar block.
And Jackie, the other question is, if there isn't easy access to a dentist, say you are the person and there's not going to be a dentist nearby or for quite some time, is it still worth giving the injection, do you think?
Absolutely. Give the patient a good night's sleep. Yeah, you know, and I think the important thing we're going to talk about tonight is the importance of telling the patient, okay, this is a problem. You have a dental issue which could very easily develop into a medical issue if you don't get it dealt with. So I think it's the doctor's responsibility to see that this patient does follow up and understand the importance of going to the dentist. Otherwise, this patient's going to be back in your clinic in a couple of weeks' time with an even bigger infection. And then you might send them away again, give them a needle, they'll come back a couple of months again, until eventually you have to put them in hospital for a very serious medical condition. So I think we need to understand the connection.
I suppose separately we'd have to talk about the access to public dentistry, because obviously that can be a problem, but that's probably a separate conversation. So one follow-up question here is, does giving the local get in the way if they are going to see the dentist in a few hours? Will that prevent the dentist from reapplying a block again?
Not at all. Not at all. Not at all. That would be wonderful. They'd be very, very good.
Okay.
But if you're at all concerned, pick up the phone and talk to the dentist and see what they want to do. If you know exactly which tooth is causing the problem, then that would be great.
All right, thank you. Jackie, we're just about halfway through, so that's my time view. Yep.
Thank you, we're getting there. So vasoconstrictors are used in local anaesthetics, and the reason that we put them in is because we want them to localise the anaesthetic to the region to be anaesthetised for as long as possible, to prolong their dental anaesthesia and to control bleeding. But there are indications where we don't use vasoconstrictors, and these are people who've had a recent heart attack or high arrhythmias, hypertension, diabetes mellitus, perhaps drug abuse. If they're on methamphetamines or cocaine, you don't want anything hanging around longer, so you don't want to put any vasoconstrictors in there. So that's dental anaesthetic. I hope that...
Sorry, Jackie, just before we get there, there's a specific question about how do you manage trismus?
Oh, yes. Okay, don't give the block. If you give the dental block, you've got quite a good chance of causing trismus. So how do you manage it? Usually it will resolve. If it's from a dental anaesthetic solution, then it will resolve in time. But there are other causes for trismus. It could be a TMJ dysfunction, it could be mumps, it could be growth. There are many reasons. So if the patients come in with trismus, then you need to look for, medical causes of that. But if they've been to the dentist recently, it's probably the nerve pranged from an inferior dental nerve block, and it'll come good usually with time.
Thank you.
Okay. So let's move on to the really good part of this presentation is some of the common oral oral presentations that will come to you in medical practice and how you can deal with them. So 3 main things that will come into you in the hospital or in your practice will be someone with oral pain, someone with a dental trauma, or some sort of an other emergency. So the oral pain could be caused by dental caries, by an abscess, by gingivitis or periodontal disease, perhaps pericoronitis, which is the wisdom tooth that's been erupting, and maybe a dry socket. Maybe we've had a lovely fly-in, fly-out dentist who flies in, pulls all the teeth out and then flies out and leaves you, the GP, to sort out any bleeding issues afterwards, and the patient has a dry socket. I'm going to teach you some really wonderful tricks to get you out of trouble with that. Then we're going to talk about hard tissue injuries such as jaw or tooth fractures. And we're going to talk about soft tissue injuries that you might come across, like tongue piercing, heaven help us, and degloving. Other emergencies we're going to look at briefly will be post-operative dental extraction hemorrhages, denture-related issues outside your comfort zone, I know, but very important for you to understand that dentures can cause problems for your patients medically. And we won't deal with the other 2 because this presentation's a bit shorter. So, dental caries. Dental caries cause odontogenic pain. So if you look back to my original picture of the anatomy of the tooth, at this point, the caries has encroached on the dentine and the tooth is really sore. And it's usually sore to hot and cold, or it's sore to sweet things.
So Jackie, just so you know, we've got several "oh my goodness" comments for your
Yes.
Yes.
Yes. So I hope you've all eaten. All right. So, oh my goodness, if you open up a patient's mouth and see this, you have to go, oh my goodness, there's something going on in here, and you can't ignore it. Because if you do, this patient will be a repeat performer for you, and they'll come back again and again to your practice until eventually you've got trouble, or to the A&E department with major problems. So if you open the mouth and you see this, you need to think, gosh, something has to happen here. You need to go to the dentist. If you don't, you'll end up in problems. The very bottom slide with the black teeth, this is quite an interesting thing. It's the solution is silver diamine fluoride, which has been painted over these teeth. Now, in the olden days, 30 years ago, when I graduated from dentistry, this was just amazing, and everyone was painting it all over little Indigenous kiddies' teeth, and it stopped decay. It was amazing. So it was fabulous, but then they decided, oh, the teeth look ugly, we're not going to do that anymore. And then over the last couple of years, it's come back in vogue, and here I am reading all this literature again about silver diamine fluoride and how wonderful it is at arresting decay. So if you see a patient come into you with teeth like that, it's possible that there's other causes, but it could well be that some very clever dentist or doctor has painted silver diamine fluoride on the teeth. So the etiology of dental caries. The picture on the right explains how caries occur. The tooth structure, the enamel, is made up of a thing called hydroxyapatite, which is the strongest crystal. And as decay occurs on the teeth, the substrates are leached out. The calcium, the hydroxy are leached out into the biofilm. Around each tooth, and I bet you're all going to rub your teeth now, you'll notice a little slimy layer, and that is called the biofilm. And that biofilm contains all these natural ingredients which will remineralise tooth structure beautifully all by itself. The saliva is in direct contact with the biofilm and provides a lot of these nutrients to remineralise a lot of these minerals. If we were lucky enough to have fluoride in our water, we would be able to have fluoride replacing some of these minerals, and we have fluoroapatite forming, which is actually stronger than hydroxyapatite. But we won't talk about fluoride because that's another lecture for another day, and I don't want death threats. So let's talk about the other way that dental caries occurs. You need 4 things. You need a susceptible tooth with a lovely biofilm on it. They all have that. You need the bacteria, and the bacteria need something to eat. So the bacteria will eat sugar or whatever food's stuck on the teeth, and the biofilm will remineralise any decay that occurs. unless another factor is put in there, and that's time. So with time, you get this nasty buildup on the teeth, on that picture on the top left, and that's plaque. And that doesn't get removed by brushing, and so it builds up. And with time, if the patient is bathing their teeth in Diet Coke or Coca-Cola or sports drinks or soft drink, or eating lollies all the time, or eating Tic Tacs all day that are releasing sugar, then we have time, and that is when decay occurs. So that's the etiology of dental caries. The dental abscess is the next progression from that. So a dental abscess occurs when pus is enclosed in the tissues of the jawbone at the apex of the infected tooth's root. Usually that abscess originates from a bacterial infection that has accumulated in the soft, often dead pulp of the tooth. This can be caused by dental decay, by broken teeth, or by extensive periodontal disease, or combinations of them all. Potentially, a dental abscess can be life-threatening. So those pictures on the side are very interesting. That one on the very bottom right shows a lovely dental abscess that is pain-free. That patient does not have pain with that tooth associated with that big amalgam filling. That abscess is draining into the mouth. So that patient wakes up every morning with a yucky taste in their mouth, and all throughout the day, the little pimple area puffs up and they just squeeze it, and they just ignore it. I've got Tennille sitting next to me going, gulp. So that's a chronic infection, which if not dealt with and treated can very seriously impact a patient's health. This sort of thing will upset someone's insulin levels, it will upset their healing, and really cause quite nasty things.
Can a patient get septicemia from this, Jackie?
Correct, they can. And they can get infections of the fascia, and yes, occlude airways. An abscess is awful.
Jackie, sorry, one just side question, which I'm so pleased came up, because obviously patients tell us all the time. Any help for dental pain with cloves? It's very much loved by our patients.
Yes, oil of cloves are in eugenol, which is the thing we treat dry socket with. So if you're on a desert island and you're stuck somewhere, I'd have a little jar of oil of cloves. It would be very useful.
And you apply that directly to the painful tooth or the gum, or?
To the tooth, to the gum. Once it gets to this point, there's no medicament that will solve this problem. We need to drain the pus from this thing. So that's the three pictures.
There's a little clove conversation going on. There was one saying, can you, and I assume the answer is correct, you can get osteomyelitis as well from an abscess, do you know, or not?
Yes, you definitely can. With a chronic infection, absolutely you can. So it's very important. And there you go. There you have a perfect example of a interconnection between oral health and medical health. So well done, whoever said that. Yeah. Okay, so those other pictures are painful, very painful. But antibiotics are not an effective way to treat most dental problems. Repeat, antibiotics are not an effective treatment for most dental problems.
And Jackie, this is obviously not going to surprise you, because there's a storm of comments about
I know.
all the patients that get sent to us where they've been told by their dentist to come to their GP to get some antibiotics.
We can prescribe antibiotics. Dentists can give it. We're just trying to delay treatment and send them to you. I'm sorry, that's the way it is. So we are just as culpable. Yes.
All right. I'll let you get on, I'm sure, because that's going to answer most of the questions, I think.
Yeah. Just hold your horses, everybody. I know that this happens and it comes up in every lecture I give, but I'll give you other things that you can do rather than the antibiotics, okay? So, and there was only one doctor in amongst the 80 that I interviewed, a little old fella who was 80 from England he was, and he said to me, Jackie, never let the sun go down on pus. And he was right, it happens for teeth as well. So the principles of managing infections, such as remove the cause, drain the pus, and support the host, have been known since the time of Hippocrates. The advent of antibiotics changed the management of life-threatening infections. However, the inappropriate use of antibiotics and increasing resistance have seen the return of severe spreading infections from common causes. Antibiotics should not be used to treat pulpitis or an infection that is localized to the teeth or to delay providing dental treatment.
So Jackie, just to be clear,
yes,
what about if it's an abscess?
That we're talking about abscess. So an abscess...
So antibiotics, I have no role in dental abscess.
Correct. Unless the abscess, and the next slide will help with that, unless the abscess has progressed to cause the patient to be unwell, as in febrile, or their face is incredibly swollen and they're very obviously sick. But if they have an abscess localized to the tooth, antibiotics won't help. You need to drain that thing and you need to get that to the dentist as soon as possible. Okay, so in your primary clinical care manual, which you've all got in your hospital bookshelves, it's about a 400-page book and there's 20 pages in there on dentistry. And it's amazing. If you could read that, I think you'll really, everything I'm telling you is in there. Well, mainly, I've got other tiddly bits.
Jackie's, one of the participants has also just reminded us that actually there's a very good NPS article on the management of acute dental pain for primary health providers.
Brilliant. That would be good. Okay.
And I'm sure you are coming to this, but someone's saying, so what are the indications for antibiotics in dental conditions? And I know you're going to cover that in a minute, aren't you?
Hold your horses, I'm there. I'm just about there. Good questions. I'm glad you're engaged with it. So antibiotic prophylaxis is no longer required for patients with orthopedic joint replacements. We used to worry about bacterial endocarditis, but we found that we don't need to. Antibiotic prophylaxis is no longer required for patients with mitral heart valve prolapse or for structural or valvular heart disease. This is what I'd like you to do. There's a wonderful YouTube video about this. It's a lovely GP who tries to drain an abscess and it's just awesome. So the one on the YouTube, they have a big abscess in the mouth and they pick up a local anaesthetic. The GP picks up a local anaesthetic and tries to force 2.2 mils of anaesthetic further into this abscess, and it is painful. You can't put any more liquid into an already distended thing. So you don't need anaesthetic, people. You just find the abscess and you very gently need to drain the pus from this thing. Using a scalpel, you cut into the vesicle. The anaesthetic is often ineffective at this site anyway due to the electrolyte balance and the pH changes. A piece of sterile rubber glove or pipe can be inserted into the incision site to keep the wound open to allow drainage until definitive dental treatment can occur. Referral to a dental practitioner for either an extraction or a root canal is imperative. You can't let this patient go around with this bit of pipe sticking out of their mouth forever. They need to be made aware that if they don't get this seen by the dentist quickly and soon, then they could become medically compromised. This is a situation where you do need antibiotics. Dental infections causing acute oral medical and surgical conditions with facial swelling require antibiotics. Ludwig's angina is rare but life-threatening infection with mortality rates close to 100%. Dental infection is the cause in 90% of cases. Bilateral infection of the sublingual and submandibular glands and facial tissues are a result of Ludwig's. Okay, so if this patient needs a little side issue, if you're going to send your patient to the dentist and you're going to give them painkillers, please don't give them any aspirin, because if we need to do an extraction, we'll have bleeding issues. So just give them the best painkillers you can and drain that abscess if you can. If you don't want to do that, then at least make sure that you've contacted the dentist and you know that that patient is on their way.
Just a side question is that we have a lot of patients on NOACs and warfarin.
Mm-hmm.
I'm assuming that your advice would be not to do sort of a drainage procedure in someone like that, because you'd have to get them to stop the NOAC for 24 hours, wouldn't you?
Well, I don't know, not really, because it's pus that's coming out. It's the smallest incision in the mucosa there, but you're just rupturing a little vesicle. To be absolutely sure, then perhaps yes, but my thoughts would be remove that pus. But if in doubt, don't do it. Ring your dentist.
Talk to someone.
Talk to someone, get your INR levels, make sure you've got all that information with you when you refer it to the dentist, so then you can collaborate together on the best form of treatment.
Just a quick question as well. You said about aspirin. Would you also avoid ibuprofen as well?
Yes.
So all NSAIDs should be avoided.
Yes. So the best thing is Panadol. Really?
Okay, thank you.
Yeah, that would be the best thing. NSAIDs if you want to, so Panadol and ibuprofen combination is okay, but definitely no aspirin. And I think to be on the safe side, avoid the Nurofen.
And Jackie, as we thought would happen, you've now got 14 minutes.
Okay, we're going well. I'll speed up. Periodontal disease has been implicated in the development of various systemic diseases, including cardiovascular disease, preterm delivery of low birth weight babies, diabetes, respiratory disease, osteoporosis, renal failure, and stroke. So gingivitis is the precursor of periodontal disease, and this is where the gums bleed if you haven't brushed them properly, and it's because you've got plaque building up. And 53% of mothers-to-be don't visit the dentist during pregnancy, yet 100% of them have gingivitis. So it's really important that you make them go to the dentist or advise them to go, and that's due to the hormonal changes. So periodontal disease is where this gingivitis has flared up and you've got plaque all over the teeth, and then the plaque goes rock hard like that nasty picture on the bottom right. And what happens then is this stuff is so hard you can't brush it off, and anaerobic bacteria breed underneath this, which cause they're anaerobic because the oxygen can't get to them, and that eats the bone, and that's the cause of a lot of these diseases. It's a commensurate thing. So periodontal disease, very important to understand the connections.
Jackie, just before you move on, just a couple of last questions around antibiotics, if you don't mind.
Of course.
A quick resource to refer people to about prophylaxis for valve disease, please.
Definitely the clown book. That's what we have, some sort of a pharmaceuticals book that understands it. I had a picture in my previous slide, but yeah, and definitely go into that clinical care manual. All the information that you need is in that.
I think as well, if I recall, there's a very good NPS article on which prophylaxis to use and when. Just a quick question, is there any treatment other than surgery to reverse gingival recession?
No. Well, you can do surgery, but no, just don't let it happen in the first place. And that's a very good question, actually. So toothache, someone comes in, if they've got sensitivity to hot and cold or sweet in one area, then it's the dental decay. If they've got generalised sensitivity to cold, then that's probably tooth erosion from Diet Coke and sports drinks, or perhaps drinking lemon in water in the morning. So a particular type of toothpaste is useful for that. And that's got, I had it written.
Kind of Sensodynes, that sort of thing, which are...
No, it's actually Sensitive Pro Relief. Now, I don't advocate any products, but you need to have a particular solution called sodium monofluorophosphate, which is what's in this particular one, and you use it as an ointment all the way around your gingival recession teeth, and that will decrease the sensitivity in your teeth. Okay?
Yeah, thank you. Someone's just said Therapeutic Guidelines has got a very good article.
That's the clown book. Therapeutic Guidelines. The dentists have got this book of Therapeutic Guidelines. It's got a clown on the front. Do you have that one as well?
No, ours is very unclown-like, but we all have Therapeutic Guidelines, yes.
Dentists have a sense of humour. So we have a clown on the front of ours, and it's been on it for about 20 years. So that's why I said the clown book earlier. I know I sounded a bit weird, but that's we refer to it in the dental.
Someone just said, yeah, that's right. But we would just call it ETG. Yeah.
Okay. All right.
We're very serious people, Jackie. Definitely. we don't laugh about things like this.
You need to meet some dentists. Honestly, let's get this repertoire happening. All right. 2 quick conditions. Pericoronitis is the wisdom tooth erupting. So if the patient is within that age range, then you need to get a nice blunt syringe, squirt some solution underneath that operculum to wash all the food and debris out, and refer that patient to the dentist to have that tooth looked at. Antibiotics are rarely required unless the patient's really febrile and sick with it. A dry socket is where the blood clot has been lost prematurely after a dental extraction. Perhaps the patient's rinsed too much or been too vigorous with sticking things into that socket, and you end up with bone exposed. So your clinical care manual suggests that you have this product called Alvogel in all your fridges, in all your hospital emergency departments. Have a look and see if it's there. If it's not, it should be. And you clean the socket out, and then you just put a little bit of this Alvogel, it looks like straw, and you put it down inside the tooth, and the patient initially goes, oh, and then they go, ah, and that's your oil of cloves. It's got eugenol in there, which is oil of cloves, as well as other things. Antibiotics are not indicated.
Jackie, sorry, just to go back really quickly, 2 quick questions. We know all about fizzy drinks and why damaging they are. Lemon juice in warm water, my understanding that's very corrosive, is that correct? And
correct.
Yeah, good.
Yeah.
Then do we know the origin of the term dry socket? Why is it dry?
Because the blood clot has been lost, so it's dry, it's exposed bone.
Okay, and then a very practical question. If someone has treated a dental abscess with antibiotic, which they're never going to do again because they now know not to, but say, and then the pain sort of settles and they're okay, patient refuses to go to a dentist, would you still strongly recommend that they go to the dentist? I'm guessing you say yes, wouldn't you?
Absolutely, because now that you know what causes that dental abscess, you know that there is a necrotic pulp inside that tooth. And until that necrotic pulp is removed, that infection will come back. And it'll come back again and again. No matter how many times you try and give antibiotics, it will come back.
Yeah. Is soda water equally damaging? Jackie, do you know soda water, tonic, that any fizzies?
Yes, because it's been carbonized with carbonic acid.
So for those of us who love a little gin and tonic, that we have to give that up.
By all means, go ahead. But the important thing is don't brush your teeth straight after. You need to let that lovely biofilm allow that tooth to remineralize, and it's all about moderation.
Okay, and sorry, one last question on antibiotics. So if the dental abscess is associated with facial swelling, like that slide you showed a minute ago, then we give antibiotics.
Absolutely.
We follow ETG, we treat for presumably strep viridans, you know, the kind of mouth, so we would go for more for a penicillin.
Absolutely. Yeah, and even IV penicillin, and admit them. And usually if they come to you at that point, they usually are fairly sick. Hopefully they've gone to the dentist, but if not, then yeah.
Okay, Jackie, I'm so sorry, we've got 6 minutes to go.
Okay, all right. Well, I'll just rush through. Hard tissue injuries. So we have fractures of the jaw, as you can see in the picture there. And simple jaw wiring, you can actually thread some fine gauge wire in between the teeth. So you've got the little gap. You can see this patient there, they're not closing their teeth together properly and their jaw is canting to one side. And it looks like there's a missing tooth, but in actual fact, it's a jaw fracture. So we need 2 teeth on either side of that jaw fracture. We thread the wire in that little triangle that exists just above the gum line and between the teeth. You can thread wire through without any pain, without any bleeding, and you pull the 2 bits of wire at the front and you use your pliers and you twist, and as you twist, that jaw closes up. No anaesthetic required, and I did this on a little 15-year-old girl who'd been kicked in the head by her horse, and it was wonderful, no problems at all. But if you're not game enough to do that, then simple jaw stabilisation with a barrel bandage. Dislocated locked jaws is where the condyle has moved forward in the socket there, and you need to wrap your thumbs very firmly in gauze so that you don't get bitten. Stand in front of the tooth, push the jaw down and back, and it'll click back into position. Once again, a lovely YouTube video if you're interested in watching that. Post-operative hemorrhage, normal oozing is normal. Inferior dental vessel being pranged, then you need to insert fibrin gels. And if it's a systemic disease, then there's probably a role for tranexamic acid. But we're getting to the crux of it. I really want to get to this bit. So if we can hold for a second. An avulsed tooth is the tooth that's been completely knocked out. If the root tip is not fully formed, remember the young tooth, then you can get it back in within 15 to 60 minutes. Then you've got a good chance of it reattaching. But if
Jackie, just quickly, how does that tooth have to be transported? Do you put it in milk? Do you wrap it in a tissue? What do you do?
Yep, next slide, it's all coming.
Yep.
Good. So put it in a container. I may as well address it. You get a little specimen jar, and if you can get the patient to spit in it and put the tooth in the pool of saliva, that's one way to bring it in. The other way is to hold the tooth up in the buccal sulcus and bring it in their mouth. And the easiest way is to put it in a container of milk. So I'm recommending that all first aid kits have a little container of UHT milk, because it's sealed, it's sterilised, it's room temperature, and you just pick the tooth up by the crown, not the root, and pop it in that solution and bring it into the doctor or the dentist. If a tooth is intruded or pushed in, do nothing, particularly if it's a baby tooth. Remember the permanent ones underneath, don't go digging. So this is the avulsed tooth that hopefully has been brought into you in a lovely jar of UHT milk. You've picked it up by the root, by the crown, not the root. You gently pop it into the root socket there and make sure it's not back to front. Eyeball it, and then you need to splint it. So some emergency splints that are quite useful for doctors. If you've got nothing else, blue tack and alfoil will do the job. Otherwise, the patient's mouth guard or orthodontic splint. We have stoma adhesive. Now, this is the most wonderful tip to take home. A little bit of stoma adhesive, if you just cut a little bit and shape it around the tooth that's been reimplanted, that will hold for a few days until they can get to the dentist, and the dentist will do that lovely splinting. Post-operative instructions, really good to give a tetanus immunisation. Oral doxycycline, the reason for that is because often the tooth has landed in soil and there are anaerobes in the soil. And so we need to have that. Chlorhexidine mouth rinse twice a day for 7 days, a soft diet for 2 weeks, and of course follow up with the dentist as soon as possible. Soft tissue injuries, we've got tongue piercings, deglovings, cheek bitings, and something interesting is the aspirin burns or chemical burns that occur. Patients often will suck on something, an aspirin or a Panadol, or maybe they'll put Tic Tacs in there and you'll get a burn from the peppermint oil in Tic Tacs. So I just want everybody to be very aware to look in the mouth as part of the oral environment to be able to connect the dots with medical and dental conditions. Really important. I know this is outside your comfort zone as doctors, but if you've got a little patient, say a little old lady who's failing to thrive, her insulin levels are all over the shop, she's really unwell, perhaps her denture's broken. You need to get used to the idea of opening their mouth, having a look what's in there. If there's a little denture, ask them to remove it. Have a look at the denture to see if there's any sharp ridges or spots that might be making eating difficult. 80% of medications cause dry mouth, which makes wearing a denture very painful. And there could be pathology under that denture. There you go, Peta-Ann, we did it.
Jackie, you are fantastic. Well done. Thank you ever so much. As per always, fantastic. Lots of thank yous. If you wouldn't mind just showing the next slide, Jackie. After this one, can you just go? No. Oh yeah, just yeah, that's fine.
That's not me. That's
Neil. Next one, please. Just showing. Next week we're doing a sexual health update, and then thank you so much, everyone, for attending. Thank you so much, Jackie. As always, I always learn something, which is just fantastic. And
excellent.
Good night, everyone, and thank you again for your participation. Good night.
Thank you.